Welcome back, everybody, to the Stat Dose podcast. We're here doing an up-to-date dose today, which is nice. We haven't done one of those in a while. And we're talking about the Fever in Under 5's NICE guidelines. It's October, no it isn't, it's November 2019. This month NICE released an updated version of that, so we thought we'd take that opportunity to discuss some of the key points. What do you mean by fever? Because actually the guideline doesn't define it, which I think is a little bit strange. But
it is strange. So a temperature over 38, I would say, 38 and over is a fever. However, when you're talking about teeny tiny babies, premature babies, sometimes you stretch it a bit lower than that to 37.6 and above.
So the neonatal period, less than 4 weeks.
Yeah, I would stretch it to if they've got a temperature of 37.6.
Yeah. Would that trigger a septic screen at that stage, or
it would trigger a senior review?
Okay.
Someone like you, Matt.
Not for a neonate.
Are you not senior at life?
My response to a neonate is it's very small. I have to call the paediatric team straight away. So how do you check temperatures? How do you go about that? Joe, you probably did it yourself. We have staff for that.
Yeah, because I'm just a lowly primary care provider. I have to do mine myself. So we get all sorts of parents coming through, don't we? And they're saying, our child's got fever, and there's all sorts of crazy devices out there, and there are devices that you can kind of shine on the head. There's infrared type sensors.
Yeah.
I'm not sure about the accuracy of those.
Inaccurate.
Inaccurate. Thank you, Lauren. So there are devices that you can put under the tongue. I think for younger children, again, probably quite inaccurate. And I think the guidance is more suggests tympanic temperature over 4 weeks is better for your tympanic, because I think usually I have a tympanic. I don't know how you check these auxiliary as well.
Because we have such tiny babies, we do auxiliary. Temperatures. And the rule of thumb I was taught from the nurses when I have occasionally had to take temperatures is if you don't make the baby cry, you haven't done it properly.
Oh gosh. Okay.
Yeah.
All right.
Because I think it's quite uncomfortable.
So under 4 weeks of age, you're really wanting to have a look at auxiliary temperatures, and over 4 weeks of age, you can go for the sort of standard tympanic.
Parents will often say, "Oh, my kid's got a temperature."
Yeah.
How do we deal with that sort of that parental reporting of a fever? Is that valid? Do we count that as a fever, or?
I think it's very valid, and you have to take note of when a parent has stated that their child has had a fever, because we know that fevers fluctuate and they spike. Yeah. So just because they present without one, who's to say they haven't given them a dose of Calpol and the temps come down? So I would never dismiss a parent saying their child has had a fever.
It's a good point as well, because kids' temperatures are very receptive to paracetamol and ibuprofen. Temperature does tend to come down very quickly.
Yeah, that's true.
And their symptoms based on temperature as well changes massively. Kids, if they have got a fever, do tend to present very, very differently to an hour later when they've had some paracetamol and their temperature's in the normal range.
Yeah, definitely. So a key part of the guidelines is carrying through of the traffic light system, which you may or may not have heard of. So as it sounds like it would, it's a traffic light system split into green, amber and red signs, or low, intermediate and high risk signs.
Yeah, I think we can quickly say on that point that obviously podcast isn't the best way to view some of this material. So
no, definitely
we'll pop a link in the show notes for the audio files, and if you're watching the new YouTube videos, we'll pop a picture up now. I'm now talking over what would be a picture.
Maybe you can see your hands.
No. Yeah, there they are. I don't know I'm doing that. Editing.
This traffic light table hasn't actually changed from the previous guideline. It's exactly the same. But the key takeaway point for anyone who hasn't seen it or used it before is that any single high risk or red feature means an urgent referral to a paediatric specialist.
I saw that and I've read that, and I see a lot of kids in practice, and Joe said we see a lot of kids in our practice. Does it happen? I mean, any red flag feature requires an urgent referral to a paediatric specialist?
No, I think they'd be very angry.
Yeah, and I think that's absolutely right. I think a lot of paediatrics generally are a very accepting specialty. Yeah. But we do get a reasonable amount of pushback a lot of the time. Certainly when it's one feature and the department's busy. One of the for colour. If you see a pale child, lots of children.
Every child that comes in.
and they've got
and it's also, you know,
It's
is
just
that
modern
history?
Britain, though, isn't it?
Yeah, is what?
Modern Britain.
Modern Britain. But it's every parent that I speak to says their child looks pale with flushed cheeks. And so I think what you're trying to say, Matt, is that it's all within the context, isn't it? So you've actually got to have one of those red flag features and possibly a bit of a kind of gestalt sort of I'm a bit concerned and maybe some sort of febrile context, you know. But to be fair, there are certain things on there, like a bulging fontanelle, that in any sort of presentation, even if I didn't have any other symptoms, that would be a concern for me.
Moderate or severe chest injury or chest recessions.
Yeah.
I see a lot of kids who have moderate recession. It's winter, either bio-induced wheeze or croup. A lot of those I will not get seen urgently by the paediatric.
But yeah, and a key one on there when we were talking about fever is babies under 3 months, even if they appear otherwise not too unwell, if they have a temperature over 38, they need a referral.
Yeah.
Oh, definitely. Yes, I think the red sort of high risk features are pretty clear. Yeah, realistically, you're probably going to get some senior advice. Amber features, do we need to be worried about those particularly?
Again, it's in the context of what this child looks like and how they're behaving, but another key point is any amber features that you don't have a clear diagnosis or source of infection, you do need to either be safety netting these parents really clearly or seek further advice from a paediatrician.
A bit of context is interesting, is it? So poor urine output is quite common in the setting of a child who's got gastroenteritis, and so I'm not going to be referring that patient.
It's a bit vague. Reduce urine output.
It doesn't give us any
give a number.
It doesn't give us anything really, does it? And as long as it's got a sign of, right, well, this patient's clearly got a gastroenteritis that we've diagnosed, we've watched and waited, they can take PO fluids. That amber flag is now something that's manageable. But actually, if we don't,
absence of red flag. And
absolutely, And so actually, but if it's a reduced urine output and we don't know why, and it's a source, it then becomes quite significantly more sort of amber flag that we need to refer on to. Yeah. And so this is that grey zone, isn't it, where you have to kind of put it alongside a diagnosis.
And that's when safety netting becomes so important. Yeah. I think because particularly from P, they're very good at saying exactly what they mean by reduced urine output. So if a kid usually has 8 a day, if they're drinking very well, it goes down to kind of 5 or 6. To a paediatrician, that's not something they're too concerned about.
I get worried if they've got less than 2 a day.
It's difficult because I did my training all back in Hull.
Famously, people from Hull don't urinate.
Yeah.
What?
It's difficult. But we've got very, different guidelines.
It's different. Different units, different guidelines.
Is what I meant. Yeah, just different expectations.
I think the key is guideline though. It's not rule. Yeah, it's a guideline, and I think what we're trying to allude to is include it in the clinical context. Yeah, nice guidelines are great generally, but take it to the clinical context. Speak with your seniors.
I think the rest of this actually, there are some pertinent things that we just need to have a talk about, but maybe actually we could do this in terms of, I'm just going to ask you questions. What's the relevance of the duration of the fever in terms of whether it correlates to how severe an infection is? Well,
I'll take this one on. No correlation at all, actually.
Does it say so the duration of the fever doesn't have a correlation?
No, I think that it's quite a common misconception is that if, particularly for parents with their first kid, you say, they've only been feverish for a couple of hours, they're not very worried about it regardless of how high. Whereas if it's been up for a few days, they start getting more worried about it. Whereas that's, from our medical perspective, it's nonsense.
It's
quite aggressive.
Okay.
Nonsense.
Okay, so that's that one.
Let's move swiftly on.
Can I tell whether it's a bacterial or viral infection based on the height of the fever?
No.
Why not?
This Q&A is going really well. No, next question.
It depends on the body system that's being infected as well. So kids can get incredibly high temperatures from a UTI, particularly they shoot right up, and that's bacterial. Whereas if it's a lower respiratory tract infection, it tends to be viral that pushes the temperature up higher than bacteria. So it's based on different organisms as well as different body systems.
Fever is such a big thing for parents, isn't it? I speak to parents on the phone all the time and say, but the fever is this, and that doesn't really matter to us. It's more about how that fever is making the child appear. So does that reducing their feeding? Yeah, paracetamol or ibuprofen?
Both. I'd usually start with Calpol.
You mean paracetamol?
Yeah, paracetamol. Sorry, no branding here. Sorry.
This podcast isn't sponsored by any particular branding. we claim no financial
Other brands are available.
I would start with paracetamol.
Yeah.
And if that wasn't getting the fever under control,
Yeah.
I wouldn't hesitate to give ibuprofen as well.
I feel like staggered dosing, whilst theoretically is good, is challenging for the parents, and quite often I'll advise them to do both. How do you feel about that?
What, double dose paracetamol and ibuprofen at the same time? The point of staggered dosing is that fevers make kids feel horrible.
Yeah.
And if you stagger the dosing, even if you never fully achieve an apyrexia, a kid constantly at the temperature of 37.8 it will be a happier child.
I agree, yeah.
There's nothing really in the NICE guidelines about it, which is a bit disappointing. But I think from practice, from my experience, I prefer staggered dosing.
Sure. Okay.
It's dependent on the parents as well. So I don't think you can kind of say, I always go for staggered or I always go for one-off.
Yeah.
Based on how complex, I guess, the parents are going to find it.
I mean, we try and discharge them with a written leaflet that says your next dose of ibuprofen is 5 mils at this time, and your next dose of Capol is this at this time, or paracetamol. Whoops. And that works quite well. It's written down. It's clear sort of timings of day.
Parents are either aware of febrile convulsions or their child may or may not have had one. Yeah. These parents come in, their child has had a previous febrile convulsion 6 months ago. He's now had a fever of 38.5 that they can't get down. Does the height of the fever correlate to the likelihood of having another febrile convulsion?
Not necessarily. It's often due to it's more of a rapid rise. It's the thing that often triggers a febrile convulsion rather than a one-off temperature, rather than the height of the fever as you describe it.
I agree.
That's good, because that's what I tell. That's what I tell them. What we're going to move on to now is that there are some diagnoses to be considered that NICE actually specify.
We're going to play another game, aren't we, Joe?
Yeah, we're going to gamify this podcast. So I'm going to play a game where I'm the patient and I'm going to give you a few fun facts as to what I'm presenting with.
Is it on the buzzer?
Yeah.
Sounds like a stat dose of fun.
And so what I want you guys to say is, when you've got it, I want you to say stop and then say the answer. Fingers on the buzzers. I'm 7 years old.
Stop.
Just asking you to stop.
I'm 7 years old. I've had a low-grade fever and I'm limping. What am I?
Septic arthritis.
No, you haven't pressed stop.
Septic arthritis?
Okay.
Stop that from me.
So yeah, septic arthritis. So we want to look out for paediatric patients with swelling of a limb or joint, or if they're not using their extremity, a particular extremity, or they're non-weight bearing. It's a really important diagnosis to consider.
Yeah.
Bizarrely painful.
Not to be confused with reactive arthritis.
Which is different. Post-viral, normally. Reaction about 2 to 6 weeks, I think. Post an infection, where you get basically arthritis in it's normally a unilateral joint, but often in the hands and knees and hips. But they should be apyrexia at that
They
stage.
should be well with a
Next round.
Next phase.
Fans.
We're actually hovering over imaginary patterns.
I am a young patient. I have a rash. The rash is polymorphous, and I also have some red eyes and a fever.
Wrong.
Let's just be stop.
Kawasaki's.
Okay, good. So Kawasaki's disease is one of those diseases that we're constantly on the lookout for, but it's actually quite rare, isn't it? I don't see it very commonly, but Kawasaki disease is something we really need to be conscious of, particularly in patients who have a fever for over 5 days. Matt, I don't know if you ever see anyone that doesn't have a fever over 5 days, because
the key is it's the consistency of fever.
Yeah.
So if they're consistently above 38, fine. If they're 38 one day and they've checked it again, it was 37.5 the following day, and then it went back up again. That's the difference when you get sort of a report of they've had a fever for a week. Actually, they've had a fever. They're not. They're back.
yes.
They're not.
And there are some other features of Kawasaki. The bilateral conjunctival injections, and it will be without exercise. It won't look like your sort of classic conjunctivitis. Strawberry tongue is quite often a sort of hallmark finding, isn't it? And sort of dryness and cracking and erythema in and around the oral mucosa, edema and erythema of the hands or feet, and quite often, I mean, the more common findings, I think, are cervical lymphadenopathy and this kind of polymorphous rash that comes out.
Yeah, so it's probably an autoimmune-mediated vasculitis, although the etiology isn't entirely clear.
I think management is immunoglobulin and aspirin.
Yeah, so it's IV immunoglobulin. The main concern is the coronary artery aneurysms, and that's why we give the aspirin, although obviously this will be under the device of paediatrics or probably a paediatric cardiologist.
Which is super dodgy, isn't it? Because you risk race syndrome.
Yeah, you do, but I mean the risk of rate is quite, it's risk versus benefit.
I have a fever. I've been unwell for 2 days. I've had one vomit with some lower abdominal pain.
Buzz? UTI?
It is a UTI. I was just about to say that there were some lower urinary tract symptoms.
Which lower urinary tract symptoms?
I was going to go more for some dysuria. Right. Clearly, this is a little bit more prevalent and easier to gain when actually you've got a child who's
talking
8, 9, 10. That's when I started talking. Never stopped since. But yeah. So vomiting, poor feeding, sort of lethargy and irritability for urinary tract infection. One more for you fun quiz lovers.
Thank God for that.
I am an ill-looking child. I've got a prolonged capillary refill time, and my neck is stiff.
Buzz, meningitis.
Yeah, so meningitis. So this is the one that we're all really concerned about. A lot of children will get referred for this for workup for a kind of query meningeal type symptoms if they're looking unwell out of proportion is really kind of what we see, isn't it? But common features are neck stiffness, bulging fontanelles in those where you're in your under twos, reduced LOC. It's always funny when I see kind of convulsive status epilepticus. It's not. That's very clear, isn't it? That child's very, very unwell.
Yeah, I mean that's probably not. That's probably more of a meningoencephalitis if you're seeing prolonged seizures.
Yeah, and most importantly, we're looking for that pupuric rash, aren't we? So non-blanching rash, pupuric or petechial. Not all non-blanching rashes obviously are meningococcal, but I think that's something to in an ill-looking child. I think that's something that needs to be ruled out once you've been observing that child for a long time, and they'll probably already get a septic workup.
At the moment of suspicion, Ben Pen or Keftraxon or whatever, straight in, if it has to be IM, just get it in.
Yeah, absolutely.
Straight away, ruins the cultures. But I think on that point, as you're mentioning seizures, herpes simplex encephalitis is one of the things we should be aware of as well. So you often get a preceding viral illness, which can progress to an encephalitis. This may present with reduced level of consciousness, seizures, as we mentioned, and focal neurological signs as well. So really here you want a lumbar puncture as soon as possible, ideally, and treatment is with acyclovir. So that's sort of the quick run through of the fever in under 5s, NICE guidelines. A few quick key summary points.
Use the traffic light system because it's really helpful. With your amber flags, because we're always wondering what to do with the grey area, isn't it? When you have red flags, it's easy. When you have no red flags at all, it's easy. It's the amber ones. So if you have an amber red flag that's something that's easily manageable, and you can give good safety netting advice, and those children are quite often safe to go home.
I'm going to go for quite a short and sharp one. A fever we can basically define as being above 38 degrees.
An important red flag that a lot of people don't necessarily realise is that a temperature under 3 months of 38 degrees or above needs a referral.
I think I will go for guidelines do not overrule clinical acumen. So clinical suspicion, get your senior review.
Yeah, talk to your friendly neighbourhood paediatrician.
Basically universally friendly.
Yeah.
I think I'll just end by saying don't get too hot under the collar about this.
Be chill.